Intracranial pressure ICP Oxford and Julian. 1. Normal ICP. 5 negative 15 mmHg. 2. Compensatory mechanisms maintain ICP until overwhelmed. 3. ICP rises steeply with small increases in volume once mechanisms fail. 4. Slow-growing lesions, large volume before significant ICP rise. 5. Fast-growing lesions, small volume can cause significant ICP rise. What is normal intracranial pressure? Around 10 mmHg or less. Sustained pressure of 15 mmHg is termed. The contents of the cranium are not compressible. Any significant increase in the volume of brain tissue, blood or CSF within the cranium will lead to a rapid rise in intracranial pressure ICP. 1. Increased brain volume, cerebral edema, swelling. 2. Mass effect, space-occupying lesion, hematoma, tumor, abscess. 3. Increased CSF volume, hydrocephalus, meningeal inflammation. 4. Increased blood volume, A. Increased CBF, hypoxia, hypercapnia. B. Increased cerebral venous volume, increased thoracic pressure, venous obstruction, cerebral perfusion pressure CPP. 1. CPP equals MAP ICP. 2. Autoregulation maintains constant CBF despite changes in MAP. Normal CPP equals 80 negative 100 mmHg. Remember that adequate tissue perfusion is not just a function of CPP but depends on blood flow and oxygen content. Cerebral blood flow CBF. Autoregulation. 1. Maintains CBF 50 ml/100 g min, between MAP 60 negative 150 mmHg. 2. Impaired in chronic hypertension, acidosis, hypoxia, hypercapnia, and head injury. Factors affecting CBF. 1. Metabolism, determined by brain demands. 2. CO2 tension, hypocapnia decreases CBF. 3. 0-2 tension, vasodilation occurs only at P02 is less than 7 kPa, 53 mmHg. 4. Temperature, decreased metabolism and CBF with hypothermia. 5. Viscosity, increased CBF with reduced viscosity HCT, 309%. 6. Anesthetic agents, how can you measure intracranial pressure clinically? There are 4 methods commonly used via the skull and a lumbar approach via a CSF catheter. 1. Epidural catheter, strain gauge transducer, a tip or fiber optically supplied light reflecting off a pressure-sensitive membrane. 2. Subdural bolt or catheter, prone to blocking and leak but less risk of infection than ventricular catheter. 3. Ventricular catheter, gold standard, accurate, CSF can be drained but risk of infection. 4. Intraparenchymal catheter, light reflecting pressure-sensitive membrane and are most commonly used. Lundberg waves, A waves, sustained pressure waves, 60-80 mmHg, every 5 to 20 minutes. Life-threatening and represent cerebral vasodilatation in response to JCPP. Need urgent treatment. B waves, small and short-lasting waves, 10-20 mmHg, every 30-120 seconds. Caused by fluctuations in CBV. C waves, small oscillations, 0-10 mmHg, reflect changes in systemic arterial pressure, anesthesia in presence of raised intracranial pressure. Symptoms and signs. 1. Early, headache, vomiting, seizures, focal neurology, papilloedema. 2. Late, hypertension, bradycardia, agitation, coma, pupillary dilatation. Management aims. 1. Avoid increasing ICP. 2. Maintain CPP 60-70 mmHg. 3. Prevent cerebral edema. Specific measures to decrease ICP. 1. Osmotic or loop diuretics, mannitol, furosemide. 2. Modest hyperventilation, PaCO2 4.0 to 4.5 kPa. 3. Corticosteroids, for tumors and abscesses. 4. CSF drainage. 5. Head-up tilt, 30 degrees, to reduce CVP. Anesthetic agents and intracranial pressure. Volatile agents. 1. Increase CBF and ICP. 2. Reduce cerebral metabolism. 3. Abolish autoregulation. 4. Halothane increases ICP most, isoflurane least. IV anesthetic agents. 1. Decrease cerebral metabolism, CBE, and ICP. 2. Exception, ketamine increases ICP. Other drugs. 1. Suxamethonium, increases ICP muscle fasciculation. 2. Opioid analgesics, little effect on CBF and ICP if normocapnia maintained. Abdominal aortic aneurysms AAA. Definition: permanent, localized dilation of the abdominal aorta, 1.5 times the normal diameter, 3 centimeters. Prevalence: 10% in men, 3% in women over 65. Mortality: elective repair, 7%. Versus ruptured AAA: 80% operative survival, 50%. Risk factors: age, 60 years, male, gender, smoking, hypertension, family history, atherosclerosis, connective tissue disorders e.g., Marfan, Ehlers-Danlos, v. Clinical features, often asymptomatic, incidentally discovered, may present as pulsatile abdominal mass. Urgent evaluation should be done. Pain, back, flank, or abdomen rupture signs, hypotension, abdominal back pain, pulsatile mass, classic triad. Indications for repair: diameter 25.5 centimeters in men, 25.0 centimeters in women, rapid growth, 0.5 centimeters in 6 months, symptomatic aneurysms, ruptured AAA, emergency repair, diagnostic investigations, ultrasound, initial screening and size monitoring, CT angiography CTA, detailed anatomy, planning for surgery, MRI angiography, alternative to CT, especially in renal dysfunction, preoperative evaluation for abdominal vascular surgery, patient profile, these patients have high incidence of comorbidities, coronary artery disease, hypertension, pulmonary disease, renal impairment, diabetes, mellitus. Risk assessment: 1. Revised Cardiac Risk Index, RCRI. 2. Assessment of exercise capacity, failure to climb stairs or walking at 6 km/h or poor exercise capacity, adverse outcomes. 3. Other cardiac risk factors: recent MI, unstable angina, decompensated heart failure, significant arrhythmias, severe valvular heart disease. Evaluation tools: identify high-risk patients with more than 3 risk factors. Do ATRIS testing. 1. Pharmacological stress tests: dipyridamole thallium scintigraphy, dobutamine stress echocardiography. 2. Cardiopulmonary exercise testing, CPET. Note: positive stress test needs further angiography and revascularization. 3. Transthoracic echocardiography, for heart murmurs. Importance: careful preoperative assessment required to identify high-risk patients. Optimization of medical management 1-2 months prior to surgery. Preoperative patient preparation. Lifestyle advice: smoking cessation and structured exercise. Medications: antiplatelet therapy, statins, B blockers for inducible ischemia. Question: when will you send the patient for his cardiac optimization? Coronary revascularization only for prognostic indications. Indications for preoperative coronary artery bypass surgery: 1. Severe left main stem disease. 2. Severe double or triple vessel disease with impaired left ventricular function, conduct of anesthesia for AAA surgery, preoperative medication, continue regular medication on day of surgery. Monitoring: standard monitoring plus, arterial line, central venous pressure, temperature, urine output, 5-lead ECG. Additional monitoring options: cardiac output monitoring, toe-esophageal Doppler LiDCO-PICO. Pulse contour analysis, CO monitoring, induction and maintenance, routine intraoperative considerations, heparinization, heparin 100 units kg before cross-clamping, reverse with protamine if necessary, temperature control, prevent hypothermia, worsens bleeding. Use forced air warming fluid warmers, increase theater temperature, hemorrhage management, minimize blood loss, intraoperative cell salvage, maintain hematocrit, 27%, HB, 9 GDL, manage coagulopathy with FFP, cryoprecipitate, platelets, cross-clamping and unclamping in AAA surgery. Cross-clamping: 1. Increased vascular resistance, arterial hypertension, 7 to 10% rise. 2. Potential cardiac failure due to increased workload. 3. Deepen anesthesia, good analgesia. AMD: use of vasodilators, GDN, SNP, to treat hypertension. Unclamping: 1. Dramatic reduction in blood pressure due to decreased systemic resistance, central hypovolemia, myocardial depressant factors. 2. Severity of hypotension is proportional to cross-clamp time. 3. Management: adequate fluid resuscitation. 2. Gradual release of cross-clamp. 3. Vasopressors, with caution. Renal system, risk factors for renal failure, a pre-existing disease. 1. Renal insufficiency. 2. Cardiac failure. 3. Hypertension. 4. Diabetes mellitus. 5. Renal artery atherosclerosis stenosis. B. Operative factors. 1. Suprarenal clamp. 2. Prolonged clamp time. 3. Hypotension. 4. Massive hemorrhage. See others. 1. Increasing age. 2. Contrast nephropathy. 3. Nephrotoxic drugs NSAIDs, ACLs, aminoglycosides, incidence of renal damage. 1. Renal failure. 5.4%. 2. Hemodialysis. 0.69%. Renal preservation. 1. Mainstay, adequate fluid resuscitation and avoidance of nephrotoxins. 2. Proposed renal protective agents, no level 1 evidence, loop diuretics, furosemide dopamine mannitol phenoldipimen acetylcysteine, postoperative care after abdominal vascular surgery, monitoring and care. 1. Close monitoring in level L, HDU, or level L, 1 CU facility, depending on patient selection and surgical complexity. 2. Early extubation and transfer to HDU possible with careful patient selection, postoperative management. 1. Early enteral nutrition to maintain gut mucosal integrity. 2. No routine use of nasogastric tubes. 3. Tight glycemic control. 4. Antacid and thromboembolic prophylaxis, abdominal aortic aneurysm rupture. Julian Barker, you are called to the ward to see a 74-year-old man with a ruptured aortic aneurysm. His blood pressure is 70/40. What are the major problems in managing a ruptured AAA, V? Preoperatively severe hypovolemia. Initial fluid resuscitation must be cautious. Assessment of concomitant medical problems. Patients are usually arteriopaths with significant coronary disease. No time for lengthy investigations. Access to vascular surgery. May need to transfer out, V. Intraoperatively. Cardiovascular instability. Induction before aortic cross. Clamping when the clamp is removed. Large blood losses, blood, FFP and platelets required. Effects of massive transfusion. Temperature control. Metabolic acidosis. Postoperatively. Respiratory support may be required for poor gas exchange and metabolic acidosis. Cardiovascular complications include hemorrhage, myocardial and lower limb ischemia. Renal failure is common due to perioperative hypotension, aortic cross-clamping. Infrarenal clamp still significantly reduces renal blood flow by about 40%. Atheromatous emboli, surgical insult, intra-abdominal hypertension, 12 mmHg, or compartment syndrome, 20 mmHg. Neurological sequelae such as paraplegia or stroke may occur secondary to damaged spinal arteries or embolic ischemic events. What is your immediate management on the ward? ABC approach, highest Phi02 obtainable should be commenced. 2 large bore intravenous cannulae should be inserted and fluids given. How much fluid would you use? This would depend on the blood pressure and the clinical state of the patient. A patient who has an unrecordable blood pressure and is about to arrest should be given fluids quickly, but in this man fluids should be given cautiously. Repeated 250 milliliters fluid boluses titrated to physiological endpoints. Consciousness, base deficit, lactate, should be used. One should not necessarily aim to restore blood pressure to normal, as this may reverse vasoconstriction and disrupt fibrin clots that were contributing to hemostasis. What else would you do? Take blood for full blood count. Urea and electrolytes, clotting screen, blood gas. Cross-match for 10 units. Consider type O negative or group-specific blood. Second, anesthetist, preferably consultant, is required. Hematology should be alerted to the need for large volumes of blood, FFP, and platelets. An assessment of coexisting medical problems and the likelihood of difficult intubation should be made. Do not delay surgery whilst awaiting lengthy investigations. Transfer the patient to the operating theater as soon as possible. Only hemodynamically stable patients can be taken for CT scanning to diagnose rupture and assess suitability for open or endovascular repair. What monitoring would you use? ECG, non-invasive BP, SP02 and capnography. Initially, surgery should not be delayed by prolonged attempts to insert arterial and central lines at this stage. How would you proceed with anesthesia, airway equipments, big drips, all vaso? Active drugs should be drawn up prior to induction. Blood should be immediately available. A method of delivering warmed fluids rapidly and continuously is beneficial, such as a level -1 TM infuser, anesthetize in theater on the table. A rapid sequence induction is performed with the surgeon scrubbed and the patient already cleaned and draped. Muscle relaxation may release the tamponade on the aorta, worsening bleeding, and the combined effects of induction agents and IPPV can cause profound hypotension. Anesthesia is maintained with an appropriate agent in oxygen air. Avoid nitrous oxide because bowel distension may increase intra-abdominal pressure postoperatively. When the cross-clamp is on and there is relative stability, invasive lines may be inserted if not already in place, like temperature probes, nasogastric tube, urinary catheter. Active warming such as with a warm air blower over the chest helps to maintain temperature, but should be avoided on the legs during clamping. Loop diuretics e.g., furosemide, dopamine, mannitol, phenoldiazepam and N-acetylcysteine have been proposed as renoprotective agents. There is no level 1 evidence to support their use. The mainstay of renal preservation is maintenance of renal oxygen delivery and the avoidance of nephrotoxin, e.g., nonsteroidal anti-inflammatory drugs, angiotensin-converting enzyme inhibitors, contrast and aminoglycosides. How would you control the hypertension associated with cross-clamping? SVR may rise by up to 40%, resulting in myocardial ischemia. If increasing the inspired, volatile concentration and giving opioid and/or propofol are not effective, then GDN can be used, especially if myocardial ischemia is present. How would you manage the patient at the end of the operation? Intensive care is usually required. Sedation and ventilation may need to be continued until the temperature is corrected. Cardiovascular stability is established and acid-base status and gas exchange are acceptable. Predictors of survival to discharge include patient age, total blood loss and post-operative hypotension, endovascular aortic aneurysm repair, EVER, ATOTW. Overview. 1. Less invasive alternative to open repair. 2. Modular bifurcated stent grafts placed via femoral arteriotomies. 3. Reduced physiological disturbances, shorter hospital stay, benefits and limitations. 1. 65% reduction in early mortality compared to open repair. 2. No long-term survival benefit in high-risk patients. 3. Risk of endograft-related complications, endo leak, anesthetic management. 1. Considerations. 1. Anesthesia in angiography suite. 2. Apnea during stent deployment. 3. Ischemic leg pain. 4. Risk of conversion to open procedure. 2. Anesthetic options. 1. General anesthesia. 2. Regional anesthesia, epidural, combined spinal epidural, continuous spinal. 3. Sedation with local infiltration, monitoring and management. 1. Invasive blood pressure monitoring. 2. Urinary catheterization. 3. Large bore venous access. 4. Anticoagulation heparin. 5. Management of ischemic leg pain, intravenous opioids, short case, postoperative confusion. Cyprian, you are called to assess a 50-year-old female patient in the recovery room who underwent total abdominal hysterectomy under general anesthesia. The recovery nurse states that she is very confused and agitated. How would you assess her airway, breathing and circulation? A, B, C. Approach. Administer 100% oxygen, check the vital parameters including oxygen saturation, pulse rate, and blood pressure. What are the possible causes of postoperative confusion and agitation? Residual effects of drugs used in anesthesia, inadequate recovery from muscle relaxants, intravenous inhalational anesthetic agents, opioids, etc. Hypothermia may contribute to impaired drug metabolism. Surgical causes: pain, acute abdomen, full urinary bladder, paralytic ileus, sepsis. Cardiovascular system: hypertension, hypovolemia, acute coronary syndrome. Respiratory system: hypoxia, hypercapnia, pneumonia. Aspiration: metabolic causes: electrolyte disturbances especially hyponatremia, hypoglycemia, dehydration, hepatic and renal impairment. Neurological causes: cerebrovascular accident, convulsion, the postictal state, intracranial pathology, infective causes, meningitis, respiratory infection, urinary tract infection, sepsis, drug and alcohol abuse, withdrawal effects. Personality or behavioral disorder. How would you investigate and treat? Reviewing the anesthetic chart to find the details, timing and dosage of drugs used will point to the possibility of a residual drug effect. Inspired and expired gas monitoring may identify residual inhalation agents. If an opioid or a benzodiazepine overdose is suspected, specific antagonists such as naloxone or flumazenil should be administered. Neuromuscular monitoring helps in assessing the degree of neuromuscular blockade. If residual paralysis is revealed, a further dose of neostigmine and glycopyrrolate can be given. The total dose of neostigmine should not be more than 5 mg. Blood glucose, serum electrolytes and temperature should be checked and the abnormalities corrected. Monitoring the vital parameters is essential. Apart from heart rate, pulse and blood pressure, the ECG should be monitored for abnormal rhythms. When simple measures fail to identify any immediately correctable cause, arterial blood gas analysis of PaCO2, PaCO2 and acid-base status can help to determine gas exchange and the metabolic status of the patient. Comment on this ECG. The ECG shows regular broad complex tachycardia with a rate of approximately 175 bpm. It could be ventricular tachycardia or supraventricular tachycardia with conduction defects. 25 EMS 1 NV 150 T Mu 700 125 L 237 CID 8 AVRV V6 www. How would you treat this patient? The management should follow the European Resuscitation Council guidelines. As this patient has a heart rate of 175 bpm and impaired consciousness, she is considered to be unstable and will require urgent synchronized electrical cardioversion. This is commenced with a 120 -150 joules biphasic shock, 200 J monophasic, and is increased in increments if this fails. She may require sedation. In a stable patient, drug management such as amiodarone 300 mg over 20-60 minutes followed by an infusion of 900 mg over 24 hours should be considered. Potentially reversible causes for the arrhythmia including electrolyte abnormalities e.g., magnesium, potassium should be identified and corrected. The following adverse signs indicate that the patient is unstable. Signs of low cardiac output include pallor, sweating, cold, clammy extremities, impaired consciousness and hypotension. Heart rate, 150 bpm reduces coronary perfusion. Blood pressure, 90 mmHg. This is most likely to be atrial fibrillation AF with bundle branch block, but a careful examination of a 12-lead ECG should enable precise identification of the rhythm. Other possible causes are AF with ventricular pre-excitation, in patients with Wolff-Parkinson-White WPW syndrome, or polymorphic VTEG, torsade de pointe. How would you treat torsade de pointe? Presence of chest pain, or presence of cardiac failure. What are the causes of irregular broad complex tachycardia? All drugs known to prolong the QT interval should be stopped. Electrolyte abnormalities, especially hypokalemia, should be corrected. Magnesium sulfate 2 grams intravenously over 10 minutes should be given. Expert help should be obtained, as other treatment e.g., overdrive pacing, may be needed to prevent a relapse once the arrhythmia has been corrected. If adverse features develop, which is not uncommon, immediate synchronized cardioversion should be arranged. Long QT syndrome. Long QT syndrome is characterized by a prolonged QT interval on the ECG with a tendency to develop ventricular tachyarrhythmias. The QT interval is measured from the beginning of the QRS complex to the end of the TWAV. The normal QT interval corrected to the heart rate is less than 0.44 seconds. It represents the duration of ventricular activation and recovery. A prolonged QT interval may lead to polymorphic ventricular tachycardia, which may lead to ventricular fibrillation and sudden cardiac death. The causes of prolonged QT interval include hypocalcemia, hypothermia, acute myocarditis, acute myocardial infarction and sympathetic stimulation. Drugs which may increase the risk of torsade de pointe include chloroquine, quinidine, amiodarone, erythromycin, methadone, thioridazine and procainamide. Key points. Immediate assessment and management of a severely confused patient involves an airway, breathing and circulation approach. Regular broad complex tachycardia compromising hemodynamic stability should be treated with cardioversion. Short case 4.1, latex allergy and anaphylaxis Cyprian, a 25-year Old theater nurse has presented for elective laparoscopy on a gynecology list. She is usually fit and well, but for the past 6 months has developed an itchy rash on her hands 10 to 15 minutes after wearing normal theater gloves. What do you think is the most likely cause of the rash? As this patient is a healthcare professional who gets a rash after wearing gloves, she is most likely to be having a latex allergy. Who is more prone to develop a latex allergy? Risk factors. The condition usually occurs in persons who are repeatedly exposed to latex. Healthcare workers, the prevalence may be as high as 17%. Rubber industry workers, patients with spina bifida, prevalence may be as high as 60%. Patients exposed to repeated bladder catheterization and multiple operations, history of anaphylaxis of uncertain etiology, especially if associated with previous surgery and hospitalization. Patients who have a fruit allergy to banana, grapes, avocado, tomato, kiwi fruit and chestnuts, they have a cross-reactivity with latex. How does a latex allergy present? A latex allergy has a wide clinical spectrum ranging from irritant contact dermatitis to life-threatening anaphylaxis. Irritant contact dermatitis, non-allergic, is due to damage to the skin from an exogenous substance. Contact dermatitis type IV, delayed hypersensitivity reaction, is mediated by T lymphocytes. It is probably a reaction to the antioxidants and accelerators used in the manufacturing process of latex rubber. A type I hypersensitivity reaction is mediated by IgE and occurs in latex-sensitized individuals on re-exposure to latex protein antigens. This may manifest as a full-blown anaphylactic reaction. Type I reactions can be of the following 3 types: contact urticaria, asthma and urticaria, anaphylaxis. If it is confirmed that this lady has a latex allergy, what precautions would you take before her operation? Inform theater staff. Ensure that she is first on the operating list. Ensure latex-free gloves and equipment are used in the anesthetic room. Ensure that all latex-containing equipment is removed from the theater to minimize airborne exposure. Ensure the availability of resuscitation drugs epinephrine, atropine, hydrocortisone, intravenous salbutamol, to treat possible anaphylaxis. Prevent exposure to latex in the recovery area. The patient may be recovered in the theater and transferred directly to the ward. The use of premedication with antihistamines and corticosteroids is controversial. In the event of anaphylaxis, what would be your management? The management of anaphylaxis from a latex allergy is similar to the management of anaphylaxis due to any other cause. Primary therapy: call for help, stop the operation, ensure that there is no ongoing exposure to latex particles, maintain the airway, give 100% oxygen and lay the patient flat with the legs elevated. Give epinephrine adrenaline 50-100 mg intravenously over 1 minute for hypotension with titration of further doses as required. Alternatively, it may be given intramuscularly in a dose of 0.5 -1 mg, repeated every 10 minutes according to the arterial pressure and pulse until improvement occurs. Start rapid intravenous infusion of crystalloids. 1 L of Hartmann's solution rapidly. 2 to 4 L of crystalloids may be required. Secondary therapy: give antihistamines chlorpheniramine 10-20 mg by slow intravenous infusion. Give corticosteroids 100 to 500 mg hydrocortisone slow IV. Bronchodilators may be required for persistent bronchospasm. Further inotropic or vasopressor support may be needed. An arterial blood gas sample should be obtained and analyzed for pH, and acidosis should be corrected. In the postoperative phase, the patient should be monitored in the HDU or 2 for at least 24 hours. Investigations: serum tryptase A blood sample should be collected as soon as possible after the initial management, and about 1 hour and 6 hours after the reaction. Samples should be stored at 4 degrees Celsius if it is possible to analyze them within 48 hours, or at -20 degrees Celsius if there is a delay. The rise in serum tryptase is transient and the concentration usually peaks an hour after the anaphylactic reaction. Elevated serum tryptase after an anaphylactic reaction indicates mast cell degradation. Later, all the events should be documented and the patient should be tested for an adverse drug reaction. Once the drug responsible for the event is identified, the patient and the primary care physician should be informed in writing. A medic alert bracelet should be given to the patient. The event should also be reported to the Committee on Safety of Medicines and on the yellow card. What investigations should be done for a patient with suspected anaphylaxis? The tests can be classified into two groups, in vivo and in vitro. In vivo tests, intradermal skin tests, skin prick tests. These tests are done with antigen solution and has a risk of provoking local and systemic reactions. The in vivo tests should be carried out in a place where resuscitation facilities are available. Intradermal skin tests are done using a more dilute solution compared with that used for a skin prick test. The skin prick test should be done for 6 weeks after the reaction. In vitro test, RAST, radioligand testing. This is a serological testing of the patient's serum with an antigen polymer complex which carries no risk of provoking local and systemic reactions. For a limited number of anesthetic drugs, specific antibodies can be measured, e.g., succinylcholine. What is the difference between anaphylaxis and an anaphylactoid reaction? Anaphylaxis is an LGE-mediated type 1 hypersensitivity reaction that results in mast cell activation and release of multiple mediators such as histamine, leukotrienes, tumor necrosis factor TNF and various other cytokines. An anaphylactoid reaction is non-LGE-mediated. Certain allergens including drugs can trigger the mast cell cascade directly without involving IgE as the initial mediator. Anaphylactoid reactions therefore do not require prior sensitization as they are direct mast cell releasers and may produce anaphylaxis-like reactions in a dose-dependent manner. Clinical features of anaphylaxis. The clinical features of anaphylaxis include tachycardia, hypotension, bronchospasm, cutaneous rashes, urticaria, angioedema, pulmonary edema, and gastrointestinal symptoms. The severity of reaction may vary from mild urticaria to severe cardiovascular collapse. Cardiovascular manifestation is the most common clinical feature, and in about 10% of patients, cardiovascular collapse may be the only feature observed. Factors that led to reduced endogenous release of catecholamine, such as beta blockers, spinal and epidural anesthesia, may increase the severity of the reaction. The clinical diagnosis of anaphylaxis may be difficult due to the wide variation in clinical presentation. Anaphylaxis referral. Following a suspected anaphylaxis, the patient should be referred to a specialist allergy investigation center. The relevant referral details should include date and time of the reaction, the presenting clinical features, all the drugs and fluids administered before the event, all the drugs and fluids administered after the event, anesthetic, technique, surgical procedure, response to the treatment and the investigations performed, propofol-related infusion syndrome, propofol. 1. Most frequently used hypnotic IV anesthetic. 2. Quick onset, brief half-life. 3. Enables fast awakening after discontinuing infusion. 4. Adjustable dosage for optimal sedation. Uses 1. Procedural sedation. 2. General anesthesia. 3. Sedation in ICU. 4. Ambulatory and neurosurgical procedures, administration, infusion or bolus or combination of both. Formulation, lipid emulsion, milk of amnesia. Propofol mechanism of action. 1. Enhances GABA's neuroinhibitory activity. 2. Acts on GABA-A receptors. 3. Prolongs GABA's action, increasing chloride channel opening. 4. Causes hyperpolarization and postsynaptic neuronal inhibition. 5. Results in hypnosis and sedation. Common side effects. 1. Pain at injection site. 2. Airway obstruction and apnea. 3. Bradycardia. 4. Hypotension. Other side effects. 1. CNS excitation, seizures. 2. Alterations in serum lipids. 3. Bloodstream infections, propofol-related infusion syndrome, pre-definition, potentially fatal condition, caused by prolonged propofol exposure. Characteristics. 1. Severe cardiorespiratory depression. 2. Severe metabolic acidosis, clinical presentation of multi-organ involvement. 1. Metabolic acidosis, lactic acidosis, hyperkalemia, hypertriglyceridemia. 2. Cardiovascular, bradycardia, hypotension, arrhythmias SVT, cardiogenic, shock, asystole. 3. Hepatic, hepatomegaly, steatosis, elevated liver enzymes, liver failure. 4. Renal, acute kidney injury, renal failure. 5. musculoskeletal, rhabdomyolysis, muscle necrosis, potentially life-threatening. 1. Cardiac failure. 2. Metabolic acidosis. 3. Organ dysfunction, elevated glucocorticoids or steroid therapy, inborn errors of metabolism, heavy or prolonged propofol, dosage, elevated catecholamines, risk factors, younger age group, critical illness, dearth carbohydrates of. Risk factors for pre. 1. Heavy or long-term propofol dosage, 4 mg/kg or 48 hours. 2. Elevated catecholamines, vasopressor therapy, sepsis, cerebrovascular injuries. 3. Younger age group, children, 18 years, especially 3 years. 4. Ongoing critical illness, severe illnesses like sepsis, pancreatitis, status epilepticus. 5. Imbalance between lipid and carbohydrate stores, excess lipids, inadequate carbohydrate supply. 6. Usage of corticosteroids, activation of ubiquitin proteasome pathway, mitochondrial dysfunction. 7. Inborn errors of metabolism, mitochondrial diseases, compromised mitochondrial function. 8. Poor oxygen saturation, traumatic brain injury, sepsis. Importance of monitoring. 1. Closely monitor patients with risk factors. 2. Consider alternative sedation options. 3. Be aware of signs and symptoms of pathophysiology of propofol-related infusion syndrome. Key mechanisms. Propofol impairs mitochondrial function, blocks electron transport chain, complexes L and IV, uncouples oxidative phosphorylation, reduces ATP production, increases production of fatty acid metabolites. Consequences: imbalance between energy demand and utilization, cellular, hypoxia, metabolic acidosis, cardiac and muscular damage, excess lipids, role of fatty acids, FFAS become primary energy source during metabolic stress, propofol impairs beta oxidation of FFAS, leads to accumulation of toxic metabolites, pathophysiology of Summary 1. Impaired mitochondrial function, reduced ATP production. 2. Blocks electron transport chain, cellular damage. 3. Leads to metabolic acidosis, cellular hypoxia, and organ damage. Investigations: CBCHB, 02 delivery, LFTs, RFTS, electrolytes, ECG, ABGS, prevention of Pre-1. Limit propofol infusion rates, 4 mg/kg, and duration 48 hours. 2. Monitor patients for signs of 3. Identify high-risk patients, critical illness, young age, vasopressor use, managing and preventing propofol-related infusion syndrome. Management of 1. Stop propofol infusion, immediately discontinue propofol when is suspected or diagnosed. 2. Supportive care, provide supportive therapy to manage symptoms and prevent further complications. 3. Novel therapeutic modalities, consider using plasmapheresis to remove toxic metabolites and potentially improve outcomes. Dialysis, specifically, sustained low-efficiency dialysis SLED, may help remove water-soluble metabolites. Extracorporeal membrane oxygenation, ECMO. In severe cases, ECMO may be considered. Neuroleptic malignant syndrome, a rare idiosyncratic reaction to antipsychotic drugs which resembles MH and serotonin syndrome. Typical patients are young. Clinical features include hyperthermia, tachycardia, extrapyramidal dysfunction, rigidity, dystonia, and autonomic dysfunction, sweating, labile BP, salivation, urinary incontinence, creatinine kinase and white cell count are raised. Patients should be treated in the ICU. Mortality approaches 20%. Table 13.1 Comparison of serotonin syndrome and neuroleptic malignant syndrome. Cause: serotonin syndrome, serotonergic drugs, MAOIs, TCAs, SSRIs, stimulants, ondansetron, St. John's, wort, tachycardia, tachypnea, hypertension, hypersalivation, hyperthermia, coma, hyperreflexia plus clonus, dilated pupils, bowel sounds, tone especially in lower limbs, discontinue causative drugs, supportive treatment, short-acting drugs e.g., esmolol. To control BP, if hypotensive, can give noradrenaline, adrenaline or phenylephrine, benzodiazepines for agitation, active cooling if needed, cyproheptadine 12 mg PO if supportive care fails, total hip replacement. Oxford. Neuroleptic malignant syndrome, not clear, but likely to involve dopamine receptor blockade, typical and atypical antipsychotics, metoclopramide, promethazine, prochlorperazine, tachycardia, tachypnea, hypertension, hypersalivation, hyperthermia, coma, hyporeflexia, normal pupils, normal bowel sounds, lead pipe rigidity, discontinue causative drugs, supportive treatment, control BPEG, clonidine, esmolol, fluid to prevent renal failure. Associated with rhabdomyolysis, benzodiazepines for agitation, active cooling if needed, amantadine, bromocriptine and dantrolene, avoid if LFTs deranged have all been used. Features, treatment, procedure. Prosthetic replacement of femoral head and acetabulum, time, pain, position, blood loss, practical, techniques, spinal with without sedation or GA plus LIA or nerve block, total hip replacement statistics. 1. Approximately 100,000 primary hip operations are performed each year. 2. Average patient age is around 69 years. 3. Cemented arthroplasties account for 26% of operations. 4. Uncemented procedures account for 35% of operations. 5. Cemented prostheses usage has decreased proportionally over time. Regional anesthesia offers several advantages and can be supplemented with sedation or GA. Prevention of thromboembolic complications is of the utmost importance. NICE have produced a guideline on the perioperative management of hip replacements. Preoperative, careful preoperative evaluation of the patient is essential. Patients contemplating hip replacement should receive advice on preoperative rehabilitation. 6. No patient should be operated on electively who is anemic. Aim for HB 130 gl in men and women, and blood transfusion is rare in X31-degree hip arthroplasty. 19. Antithrombotic measures should commence on admission. Perioperative, place an 18G or larger cannula in the upper arm, if a lateral position is anticipated. Ensure adequate hydration prior to performing spinal anesthesia and during cement insertion. For single-shot spinal anesthesia, 2-3 ml of hyperbaric bupivacaine 0.5%, depending on patient size. Diamorphine, 0.25 to 0.5 mg, may be added for more prolonged analgesia but can cause unpleasant PONV. When using spinal anesthesia in the lateral position, TCL propofol is a useful sedation technique, with face mask supplemental 0.2, 60-9 amin, lateral or supine. 300-500 milliliters. Avoid benzodiazepines in the elderly, as their use may lead to acute delirium. Epidural analgesia is rarely indicated for X31-degree hip arthroplasty. Peripheral nerve blocks offer some advantages over systemic analgesia. Aim to maintain BP at an adequate level. Based on preoperative readings, hypotension is not indicated. Intraoperative antibiotic prophylaxis as per local protocol will be required. Actively warming the patient reduces intraoperative blood loss significantly and reduces morbidity and mortality. Consider IV tranexamic acid. Postoperative, surgeons usually prefer the patient to be placed on their bed in the supine position, with the legs abducted using a pillow, to prevent dislocation of the prosthesis. Antithromboembolic prophylaxis is important. At least 1% of patients develop DVT, even with measures in place. 0.2 therapy for up to 24H is advisable in most patients. HB should be checked 24H postoperatively. Patients are mobilized as soon as possible after surgery. Ideally, rehabilitation should be offered on the day of surgery, if possible. 6. Simple oral opioids with regular paracetamol or NSAIDs are usually sufficient for postoperative analgesia. Caution with NSAIDs in the elderly. Bilateral total hip replacement. This procedure is now rarely performed. Around 5,000 have been recorded by the NJR since 2006. In the latest NJR report, there were 386 bilateral procedures performed. Out of around 100,000 cases, revision of total hip replacement procedure, revision of previous total hip replacement, time: 1-4H, depending on complexity, pain, position, lateral or supine, blood loss, 1L, occasionally considerably more, X-match 2 units, practical techniques, regional or GAT nerve block, preoperative, general principles as for total hip replacement, except, the operation may take longer, but timings are variable. Discuss with your surgeon beforehand. Blood loss can be significant, with 1L or more commonly lost perioperatively. Postoperative pain can be a significant problem. Perioperative. 1. Urinary catheter. 2. Arterial line and near patient monitoring for significant blood loss. 3. Consider nerve blocks or supplementation with GA. 4. Blood recovery and autologous transfusion. 5. Availability of X-matched blood. 6. Consider IV tranexamic acid. Postoperative. 1. Mobilization varies with complexity of revision. 2. PCA suitable for pain management. 3. Supplemental 02 for 24H or longer. 4. Thromboembolic prophylaxis essential. Total knee replacement. Procedure prosthetic replacement of the knee joint. Time 45-90 minutes. Position supine. Practical techniques: spinal analgesia plus LIA, GA plus LIA, pain plus. Blood loss minimal with tourniquet 250-500 milliliters without. G&S, ultrasound guided adductor canal block. 17. Similar patient population to hip surgery. Often a shorter operation with less blood loss and less chance of cement hypotension. A tourniquet is commonly used, so be aware of tourniquet pain. Postoperatively, pain can be extreme and must be anticipated. There has been a move towards nerve blocks that spare the motor component, so that mobilization is not impaired. An example of this is the adductor canal block. NICE have produced a guideline on the perioperative management of knee replacements. Preoperative. Careful preoperative evaluation of the patient is essential. Patients contemplating hip replacement should receive advice on preoperative rehabilitation. 6. No patient should be operated on electively who is anemic. Aim for HB 130 gl in men and women. And blood transfusion is rare in X31-degree hip arthroplasty. 19. Antithrombotic measures should commence on admission. Perioperative. The patient is always supine, and therefore, airway control under sedation can be a problem. Spinal anesthesia, with or without intrathecal opioids, is the preferred technique. 22. GA is often used. A tourniquet is commonly used. Therefore, perioperative blood loss is not problematic, although expect to lose up to 500 milliliters, and frequently more, from the drains in the first hour postoperatively. There is a trend to reduce the use of the tourniquet. Consider IV tranexamic acid. 6. If a tourniquet is used, one may see breakthrough of tourniquet pain after about 1H, causing CVS stimulation and hypertension. This is more common with leg blocks and is treated by deepening anesthesia or adding IV opioid. Ketamine 0.25 mg/kg is effective at preventing the associated rise in BP. Ensure the patient is well preloaded before the tourniquet is released. A short-lived reperfusion event is common and is usually best prevented by fluid loading before and during tourniquet release. Postoperative pain is usually the most significant problem, and this is the main determinant of the anesthetic technique. Many patients are now already on opioids, and this makes the management of postoperative pain more difficult. When blood loss into the drains continues to be brisk after the first 500 megaliters, the surgeon will often clamp the drains for a period of time. Ideally, rehabilitation should be offered on the day of surgery if possible. Bilateral total knee replacement. Bilateral knee replacements should only be considered in young, fit, motivated patients. Elderly patients and those with significant CVS disease are high risk. The advantage is that 2 admissions operations are avoided. The disadvantage is that bilateral total knee replacement is a major CVS stress and is associated with unpredictable blood loss and fluid requirements. This can be achieved under regional anesthesia and bilateral adductor canal blocks, but frequently GA may be required for over 2H of surgery. Revision of total knee replacement. Same as X31-degree knee replacement, except it takes longer. 22H. The technique is as for X31-degree knee replacement. If done without a tourniquet, 2 units of blood should be X-matched. Abdominal compartment syndrome, Buddy plus NCBI